my screen and you can see me writing on it,
Yep.
then maybe we're on the right track. Fantastic. Okay, I'm not sure what you guys were really looking for tonight, so I'm just going to do kind of a general review on what the systematic approach to looking at these EKGs should be, and then I can kind of walk you through practicing some of those if you want, and we can take it from there. So does that sound okay? Yeah?
Yep.
Yes.
Okay.
Yes.
Okay.
Yes.
If you need something else, let me know, and we can try to figure out how to make that happen here. So really, when you get down to it with a systematic approach, every EKG you look at, you should try to follow these steps, and you'll be in good shape. And I'm going to walk you through what those are and just remind you why we do those things. So first thing you should be doing on every EKG is looking for the rate, and then you need to look to see whether or not the rhythm is regular or irregular, the QRS is narrow or wide, whether or not there's P waves, and whether or not they're upright in 1 and 2 and inverted in AVR. And then we've also added recently, what is the duration of the PR interval? Okay, those should be from the book. All that sound familiar? Thumbs up. Good. Okay. So when it comes to calculating the rate in the real world, when you guys get into clinicals and you get into practice, really the computer is going to be reliable 99% of the time. And so really the methods that we're teaching here are just ways you can manually calculate it in case things don't go well with the computer. Now, the main thing is, don't get hung up. I mean, I know on these test questions, it's hard for as PA students not to get hung up on is it 55 or is it 57? But really, honestly, when we look at the rhythm, when you get to looking at enough of these, you'll know if it looks slow, it looks normal, it looks fast. And that's kind of what we're looking at anyway, okay? But when you have a regular rhythm, there's several different methods you can use. It can be the count-off method. It comes from Ben's book, the 300, 150, 100, 75, 60, 50, right? The 300 method is the exact same thing, except we're counting the amount of large blocks that are there and dividing that by, or 300 divided by the number of large blocks, and that'll give us our rate. To get a little bit more accurate, you can use the 1500 method, which is counting the number of small blocks. So 1500 divided by the number of small blocks, and that'll be a bit more accurate than these other two methods. Now, the 6-second strip, you can do that with the regular rhythms, and you can also do that. It's really the only way to get an accurate rate with an irregular rhythm. So you have to kind of count out 6 seconds. Now, I know the workbook, it's not perfect. Maybe there's only 5 seconds on there. Well, guess what? You can figure out a rate with 5 seconds. Instead of multiplying it by 10, you'd have to multiply it by 12, right? Just doing the math to figure out what it would add up to in a minute. And that's really what we're trying to figure out. Now, the reason we do the rate is because if we can put these into categories of fast and slow or normal, we can begin to make a differential diagnosis as to what rhythm we're talking about. So if we're talking about fast rhythms, then we can think of things like sinus tachycardia, SVT, multifocal atrial tachycardia, and sometimes atrial fibrillation and atrial flutter. Those will get pretty fast. Slower rhythms, maybe we need to put them in the category of sinus bradycardia or an escape rhythm like junctional escape rhythm, or we haven't gotten to it yet, but a ventricular escape rhythm. Those things are slower. Again, as we move further down in the downward displacement of the pacemaker, the slower rates that we get, and that's what these escape rhythms are there. So if you know if it's fast or if it's slow, you can begin to eliminate certain things that typically are fast or slow, and kind of narrow your differential based on that. The regularity of the rhythm is also very helpful for that. So we march out the R to R intervals if we're looking at the ventricular regularity to see if those match out. Now, if there's some that are closer together and some that are farther apart, then we see that there's some irregularity there. And so then we have to figure out, is that a constant irregularity, or is it just kind of a one-off beat that would be something like these, I'm trying to draw now, here we go, these ectopic or premature beats, right? So if you got a one-off beat, then maybe it's just an ectopic beat. If it's a constantly irregular, then maybe it's something like the atrial fibrillation that we just talked about, okay? So regular rhythms would include these up here. So that's another reason why we look at the regularity. Again, just kind of trying to make the differential diagnosis a little bit more narrow. The QRS width, that's another very important thing for us to look at. So if it's narrow, then we are thinking supraventricular. If it's wide, we haven't really gotten into too much of that yet. We will this tomorrow. We'll talk about ventricular rhythms. So all narrow complex rhythms originate above the ventricles in our supraventricular rhythm. So as we begin to, you can eliminate these things that we're going to be talking about tomorrow if it's a narrow complex rhythm, right? But if it's wide, then we can think about Wolff, Parkinson, White. We can think about ventricular rhythms that we'll get into tomorrow, and bundle branch blocks that we'll get into later on. So noting the QRS width. Basically, you're just looking for rate, the regularity, and then we're going to start looking at these intervals, QRS being one of those. P waves would be the next thing we can look at. And if they're present, then and they're upright and leads 1 and 2 and inverted in AVR, then we've got a sinus rhythm, right? If we've got P waves that have multiple or several abnormal morphologies, and we're talking about things like MAT, moderate atrial pacemaker. Maybe it's a single beat like a PAC or an atrial escape beat, or these atrial escape rhythms that have abnormal P wave morphologies. Again, like with a junctional escape rhythm, we either have no P waves at all, or maybe it's an inverted P wave like that and leads 2 and 1. If there's no P waves at all, we think of things like SVT, where the P waves are essentially hidden within the QRS complex. If it's no P waves at all, but we've got a non-isoelectric baseline with a lot of quivering within atrial fibrillation. Junctional escape rhythms could be missing P waves altogether, and sometimes
Music.
Yep. Somebody needs to mute their mic if they're playing music right now. Thanks. So when we have atrial flutter, we don't really have P waves, but we have those sawtooth waves, right? Called flutter waves, and so that will help us to determine that. So we're looking at the P wave morphology. If they're present, are they upright where they're supposed to be, or are they inverted or things like that missing? Okay, sorry, I got dogs whining in the background. PR intervals would be the next thing that we look at, and the reason we've added that recently is because of looking at Wolff, Parkinson, White. If you remember talking about WPW, it's going to have a very short PR interval, the delta wave, and then the wide QRS complex. That's pretty bad. But you have a very short PR interval. You have the delta wave where it slides into things, and then the wide QRS complex. Junctional escape rhythms, maybe that inverted P wave is immediately before the QRS complex, so we're looking again at the PR interval. It's very short, then we can think things like junctional escape. And then we'll get into AV blocks in a couple weeks where we end up having prolonged PR intervals or irregularly varied PR intervals. Everybody with me so far? Let me know if we're moving too fast or you need me to slow down, okay? So by the end of this course, what I would love for you to be able to do when you look at an EKG, especially a 12-lead EKG, is give a complete interpretation. Right now, all we're really focusing on is naming the rhythm and a rate. So it should look, your complete interpretation at this point would be as simple as just naming the rhythm and the rate like this. If there's some ectopy there, then you can say the occasional PACs, which there's not here, but then you would add things like that, or you could say maybe the patient had WPW. This would be the complete interpretation thus far. So right now we're doing rate and rhythm. As we move along, though, you'll have to add these things to your complete interpretation. Not only is it just important clinically to be able to make note of these things, but also when you want to make money and keep your office open to bill for these EKG interpretations that you'll be doing, the insurance is going to be looking for some of this information in order to think it's complete and pay you for it. We all want money, right? Got to pay off student loans. All right, so the things that you really need to know for this course, for the midterm, and the things that I want to make sure you get out of it is understanding the foundational concepts, like knowing what the SA node is and the AV node is, the anatomy and physiology, and then making sure you kind of understand how the EKG picks up the information. So those 4 laws of EKG are important to know, and those are the kinds of things we'll be looking for in the midterm. Especially, there'll be a multiple choice portion. It's basically going to be these foundational concepts. Now, identifying the rhythms, so you need to be able to do that. You need to be able to recognize atrial fibrillation when you see it, and atrial flutter when you see it. And if you know the rhythm, it would be helpful to know how to treat it when you see it. So these things are important too. Things that put patients at risk for particular rhythms, maybe the symptoms that would be associated with it, and the treatments. A lot of the treatments are going to be pretty similar.
Roberts?
Yeah.
For chapter 8, when they go into treatments, do you want us to go into the specifics of each exact treatment, like know what is involved in rate control? Or do you just have to know basically, oh, you got to control the rate, you got to restore rhythm? Do you want us, how specific do you want us to go?
Yeah, good question. So with things like atrial fibrillation and atrial flutter, the books, I think it talks about, and in class we talked about rate control, rhythm restoration, and prevention of thromboembolic complications. Those are kind of the big three. It is beyond EKG course, and maybe even, I don't know, beyond, maybe we'll get into it in Clin Med, the very specifics like when and what, like with beta blocker. I think in general, if you know these classes of medications, like beta blockers are made to slow rates, and calcium channel blockers are made to slow rates. Those are things that would be good to know. I'm not going to ask medication dosage and all that stuff. Okay. Adenosine would be the thing we would think about for SVT. You would need to know about cardioversion being an option for that. And then we think about atropine for the slow rates. That would be something to know as well. Okay. So really it comes down to adenosine, atropine, when you shocking people, and then basically beta blockers, calcium channel blockers, and maybe digoxin. And a lot of these things are going to be the same. So basically these are made to slow things down, and this is made to speed stuff up. Okay. So it's really not too, sounds maybe overwhelming, but it's really not that much. There's probably 5 answers. You know what I mean? Okay. Does that help?
So basically, you do want us to know the specifics of each one?
I guess so. So when it comes to SVT, know that we give adenosine, okay? So if you don't remember, when it comes out to SVT, the very first thing that we would try to do are vagal maneuvers. And if that doesn't work, then we move on to adenosine. Now, the way that's given is rapid IV push. This medicine doesn't last for very long, just a matter of seconds. So we've got to get it quickly into the bloodstream. So what actually happens in practice is they'll give 6 milligrams of adenosine through a big bore, like an IV. Usually it has 2 ports. One, they'll push the medicine as fast as they can, followed by a saline flush into the other port to make sure that medicine gets through. It'll kick in very quickly and wear off very quickly. It causes basically the AV node to stop functioning altogether. The patient will go into asystole for maybe a few seconds, and they're going to feel like total crap while that's happening. But that is a super common treatment for SVT, and I mean, you should be aware of that. So vagal maneuvers and adenosine go together with SVT. Anytime you've got a symptomatic patient with bradycardia, so let's say there could even be sinus bradycardia, their heart rate's in the 40s, their blood pressure's crap, and they're feeling like they're faint, atropine is going to be the medication for that. Same thing for maybe a junctional escape rhythm or a ventricular escape rhythm. They're really, really slow and they're symptomatic or unstable, then we're using atropine. Okay. When it comes to these like atrial fibrillation and atrial flutter, I don't know if we talked about it really enough in class, but when these patients are symptomatic and unstable, they get electricity. So cardioversion would be the treatment for that. A little more long-term or maybe they're a bit more stable, we'll give IV calcium channel blockers and beta blockers to slow the rate. So these are things that would typically be used to slow a rate. So that, I mean, you're looking at these 3 categories, and that's kind of it. So, so that's the thing I'm looking for. Okay.
So I'm sorry to interrupt really quick. So beta blockers, calcium channel blockers, and digoxin, those are meant to slow down the rate for AFib and atrial flutter?
Yeah, and so they're used in a lot of these tachycardia, rhythms and stuff. So where was I at even? So yeah, those would be things that would be used to slow down the rate. Not sure. Does that help? Is that answering your question or no?
Yes, thank you.
Okay. It's all in, these things are in the book. You can look over them again, but again, it's not going to be like necessarily how much or, how often. I think in the book, it'll talk about atropine going up to 3 milligrams. Not too worried about that. It'd be great to know it, but that'll be stuff when we get into ACLS. That's going to be part of part of that. You'll have to know that for your ACLS course. And it used to be in the summer, but I think now it's probably this fall. Does that sound right? Have they told you that? Anyway, ACLS, Advanced Cardiac Life Support, learning to do CPR, when to shock, when to give medications. That'll all be part of that course. So questions about the systematic approach, questions about what I'm looking for at this point. Does that make sense?
Mr. Roberts,
Yeah.
I'm identifying the rhythms just from the examples in the book. I'm just not sure exactly like how to distinguish them from each other.
Okay. So that's the next part of what I've got here is I'm going to run you through a bunch of rhythms, and we're going to work them out together and just try to sort that out. Okay. Best we can online. So, so here's a rhythm here. Okay. So we're going to use our systematic approach and start out with the steps that we need to figure out. So what would be the first thing we need to do? Anybody?
Rate.
Thank you. All right, rate. That's the number one thing. So what is our rate for this rhythm? Daggum dog.
$130.
Okay, it's pretty fast, isn't it? So here's one for those who maybe still having some trouble with the rate. One thing you can do is look for a QRS complex that lands on or near dark black, on or near one of the bold lines. Here's one right here. It lands right on that line. That makes counting the blocks pretty easy, okay? So there's one big block, two big blocks, and if I wanted to count the small ones, it looks like there's 1, 2, 3. So I've got 10 plus 3, so I get 13 small blocks. And if you were to calculate that, you got what, 130? What do we say with the rate?
So do you do?
So if you want to count the big blocks, you can. And so what it would be is 1, 2, and maybe about a half of another. So you would have 2.5 big blocks. So that's one way to do it. And that would be your 300 method, right? Or you can do the count off, and you can do 300, 150, 100. And we know it's somewhere between 150 and 100. So maybe it's about 125. Does that make sense?
Yes.
Yes.
Okay.
Yes.
So really, when you look at this, even if we didn't know the exact rate, we say, man, I think that rate looks like it's moving along pretty quick. So we can see this is a fast rate, right? So we have to start. Now, the thing is, this one's probably a terrible example because it's not typically a fast rhythm. But anyway, we're going to walk through it nonetheless. Okay. Hey, buddy, what you need? I don't know where it's at, bud. Okay, what's the second thing we need to look for?
Rhythm.
Okay, so is it regular or irregular?
Looks regular to me.
Regular.
It's regular.
Yeah, you're right. So we move.
It's
mark these out.
regular.
It's regular, yeah.
Regular. Okay. So we've got a regular rhythm that's moving fast, and then next thing we're going to look for, dadgummit. And then so the third thing we need to look for is what?
QRS.
Okay.
P
so
waves.
QRS. P waves would be, yeah. You can do these in any order as long as you got a pattern. I think the next one in our order is QRS usually. So is it narrow or wide?
Narrow.
Narrow.
Okay. So far we know we got a fast regular rhythm that's coming from above the ventricles, right? So we'll have to figure out exactly where. And the next thing would be to look at those P waves. Okay, so looking at the P waves to determine if it's sinus or not, which leads would we look in?
1, 2, and AVR.
Very good. 1, 2, and AVR. And we want those P waves, if it's sinus, to be upright in 1 and 2 and inverted in AVR. What do we got going on here?
Inverted in lead 2 and 1. And it's upright in AVR.
So that's backwards, right? So we know that this is not a sinus rhythm. Okay. So we can do that so much so far. So let's do the next step before we make a call on it. So the very next step would be what?
PR?
Very good. The PR interval. So a normal PR interval should be 0.12 to 0.20. This, if you look at that PR interval, is very, very short. That P wave is immediately before the QRS complex, right? Yeah. So we have a short PR interval. Now, so we got a fast, regular rhythm that begins above the ventricles, but is not sinus when it has a short PR interval. Even though we did not specifically talk about this rhythm in the class, it is mentioned in the book, at least in the margin. Hopefully you'll be able to put this information together and tell me where you think the primary pacemaker is coming from.
AV node, or just above the AV node?
Yeah, good. So this is not a sinus rhythm, but it's coming from the AV junction and it's retrograde depolarizing the atria. And so we get an inverted P wave. This is called an accelerated junctional. I apologize for this writing. So accelerated junctional. So even though we're used to a junctional probably being 40 to 60 beats per minute, this is still coming from an AV junction, but it's going faster than we would expect it to. We know it's supraventricular, so it's above the ventricles because it's narrow. We know it's not coming from the SA node. So we really have two options. That would be either an atrial ectopic focus or the AV junction. And if you remember back to talking about the PR interval, that's where we can kind of differentiate between those two. The real short PR interval, theoretically, it's coming from the AV junction. A longer PR interval, it's coming from an atrial focus. Everybody follow that okay?
Actually, you lost me a little bit. So if you've got a shorter PRI, it's coming from the AV area, whereas a longer PRI, you've got it coming from more the SA node. How does that go with the inverted P waves?
Okay, let me see. I should have, I'll try to do my little drawing here if I can. So if you've got the heart, let me just lay this flat, try to draw on this.
That looked like a penis at first.
Hey, it is a penis.
I know. I know that is under Kendall Marlar's name. I did not say that.
Oh my God.
Okay, I'm not even seeing the comment, so it's okay. Everybody's cool. So the question we got off on penises. The question was, how do we know where is it? Can you rephrase your question? Does anybody remember?
Yeah, I don't know if I can rephrase that question.
Or just say it again.
So how does the shortened PRI versus the longer PRI come into play with the inverted P wave? Because the inverted P wave indicates that it's going in the opposite direction, right?
Correct. So if the AV node here is retrograde depolarizing the atria like this, okay, then we have AVR up here and we've got 2 down here. It's going to be heading towards AVR, which means AVR is going to have an upright P wave, and it does, okay? So an atrial ectopic focus can be low enough in the atria, like down here somewhere, okay, and also retrograde depolarize the atria. But in theory, and again, this is not proven, it's just all we can figure out from the skin electrodes, okay? In theory, they say if it's coming from an atrial ectopic focus, that the PR interval is going to be a bit longer because it has more distance to travel to get over here, okay? If you're already starting the AV node, it's going to be immediately depolarizing the ventricles, and so you get this right here. If you have an atrial ectopic focus, it's going to be a little further from the AV node. Therefore, even if it's inverted because it's going retrograde depolarizing the atria, that it's still going to have some distance to travel to get to the AV node, and therefore the PR is going to be a bit longer. Does that help?
Yeah. One last thing. Clinically, how important is that? Like the distance of the PRI based on,
to treat an atrial ectopic rhythm versus a junctional ectopic rhythm, I couldn't care less. If you don't know the honest truth, clinically speaking, it makes no difference to me whatsoever. What matters is the patient symptomatic or not? And you know, if these patients are athletes, it's not uncommon for them to necessarily have an atrial ectopic or junctional ectopic rhythm, or escape rhythm, and they're probably going to be fine, and I don't need to do anything other than just make note of it. But you get these older people, maybe they've got the SA nodes failing on them. If they're symptomatic, their heart rate's in the 40s, their blood pressure's terrible. Then again, what do we give for those slow rates? Well, it's going to be atropine, okay? You speed those patients up. And that's when it would clinically matter, is what the rate is and how the patient's doing. But that's it. Make sense?
Makes sense.
Okay, we're moving on then.
I have a question.
Yeah.
So you said that atrial, something that's coming from an ectopic place in the atria is typically a long PR interval, so that would be anything longer than 0.20?
No, it won't be prolonged. It'll just be longer. I forget, I think it's anything for, whoa, I was hoping it was going to stay blank. So for junctional, I think it's anything less than 0.12. So anything less than normal. Whereas the atria ectopic is going to be anything greater than 0.12. So is the PR interval greater than 3 small blocks here? No, it's hardly a single block, right? So that falls into the category of, it's most likely a junctional ectopic. Did I clarify?
Thank you.
Okay. Next one. Any what? Rag? No. We need to step out while we do this. Okay. Sorry, my wife's having a meeting too, and I've got 5 kids all looking for a parent to just, for whatever reason. Okay, so what's the very first thing we start out with on each EKG? So let's start out with this one. Let's do this one. The rate, right? So part of this is, if you look at this rhythm, you can see, well, maybe we should do this one. Regularity. Is it regular or irregular?
Irregular.
Yeah, so we have an irregular rhythm. So the only way we can calculate an irregular rhythm is what method? The rate for an irregular.
30 block method.
Yeah, we got to count these stupid blocks, and I don't really want to, but we will. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22, 23, 24, 25, 6, 7, 8, 9, 30. So 1, 2, 3, 4, 5, 6, 7, 8. So we have a rate of approximately 80, okay? We have a pretty normal rate, not too fast, not too slow, kind of in the wheelhouse here, okay? Whoops. Okay, so we got a rate around 80, and we have an irregular rhythm. So what do we figure out next after we do rate and regularity?
QR interval.
Very good. Is that narrow or wide?
Narrow.
Yeah, good, because all of our rhythms thus far are pretty much narrow, aren't they? So number 4 would be, what's the next thing we look for?
P wave.
Good. So what do you see about the P waves here? So upright in 1 and 2, inverted in AVR. So we've got what looks like a sinus rhythm here, right? It looks like it's coming from the SA node based on those P waves. Number 5 would be the, what's that?
Why? Okay, if I'm looking at V3,
Okay.
could I not interpret those waves as being wide?
QRS complex?
Yeah.
No. I'm trying to see how I can measure it. So without being too, it starts here and ends here, and I'm counting 2 small blocks in the middle. Looks like a smiley face, which would be 0.08.
I was looking at that humongous hump in the middle.
I think you're looking at the T-wave, Kendall.
Are you talking about these right here?
Yeah, I'm dumb. Sorry, ignore me. Bye.
Okay. Yep, those are the T waves. All right. I lost all my notes, didn't I? Number one, we had a rate of 80. We had regular rhythm. We had a narrow QRS. We got P
Actually, I
wave.
think it was irregular.
Oh, you're right. Thank you. Irregular rhythm, P wave. Dadgummit. P waves look like they're sinus. And what's the next thing? PR interval. All right. That's normal. Okay, so we're looking for a rhythm that is irregular, coming from above the ventricles, and it's coming from it's coming from a sinus, the SA node. So what does that fit into? An irregular rhythm that's from the SA node.
I'll take a stab at this one.
What's
Can
that?
can I choose a fib for 300, please?
You can choose that, but I would not. Okay, so that's a good one because you think about your irregular rhythms, atrial fibrillation is absolutely in that category. Okay, now the thing with atrial fibrillation is there should not be P waves. We have P waves are missing when we have this fibrillatory baseline. So if we have P waves that are telling us it's going to be a sinus rhythm, then we have a sinus something. Okay, so is it sinus bradycardia? Is it sinus tachycardia? Is it sinus rhythm? Is it sinus? Yeah. Anybody? Arrhythmia. Okay. The sinus arrhythmia. All right. So if we have upright P waves in 1 and 2 and inverted in AVR, P waves are present and they fit the definition for sinus. So we know it's coming from the SA node. That rules out atrial fibrillation, that rules out atrial flutter, that rules out junctional rhythms, that rules out ventricular rhythms. We're basically narrowing it down to which type of sinus rhythm do we have, okay? And when it's irregular like this, then we call it a sinus arrhythmia. Does anybody remember why you have the irregularity with sinus arrhythmia?
Respiratory difference.
That's right. The changes in the vagal tone associated with inspiration and expiration, okay? Very good. Questions on that one?
So, quick question.
Yeah.
Why would it not be WAP?
Okay, so let's think about it. P waves is where that kind of helps us to determine that, right? So P waves with wandering atrial pacemaker should have at least 3 different P wave morphologies in the same lead. Now, if you look at these P waves, you're going to see that if you were to copy and paste them on top of each other, that they essentially will look the same. Okay. But that's another irregular rhythm. You'd be right to put that in your differential. But looking at the P waves would be where we would make that differential.
So they have to be the same morphology within the same line or the same lead, basically.
Yeah, because if we change the perspective that we're looking at, we go from an inferior lead in lead 2 to a lateral lead in AVL to a precordial right-sided chest lead in V2 to a lateral left-sided chest lead in V5. All these are having different perspectives. So all the P waves, therefore, are going to look a little different because they're all viewing the heart from a different angle. Now, if we were to look at them all in lead 2, that would be okay. You've got a rhythm strip like this one down here at the bottom, then you can use it, and that gives you a little longer strip to kind of look at. But yeah, it has to be in the same lead, or otherwise it's going to look different just because of different perspectives. Somebody's looking at the horse from the front, and somebody's looking at the horse from the back. The horse is going to look different, right? So, got to be the same picture. All right, one more. And to determine this one, if you were to look at it just in a glance, does it look regular or irregular?
Irregular.
Good. So we have to do the stupid, 30 block thing again, right? 1, 2, 3, 4, 5, 6, 7. 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 2, 3, 4, 5, 6, 7, 8, 9, 30. Okay, so 1, 2, 3, 4, 5, 6, 7. It's around 70. So even without counting that, I could have told you this looks like a pretty normal rate. It's not too fast, not too slow. And so 70 is a good number. We'll take it. So the rate is 70. We have an irregular rhythm. The next thing we would want to look at is the QRS complex, right? And this would be what?
Narrow.
Very good. All of them been narrow so far. And then the next thing would be,
P waves.
what's next? Good. P waves. All right. So we like to look for P waves in 2-3 and AVR, particularly because we're looking for sinus rhythm. What do you see here?
I see nothing.
None. It's not
Good.
us.
Congratulations. You're right. There are no P waves. What do you see instead? Can you?
However,
Okay.
Mr. Roberts,
Yes.
there's people here with me that are wondering why those little blips, specifically kind of right under the not sign next to your P waves. If you look
Yep, right
straight
here.
down, yep, there you go.
Yep. That's going to happen from time to time in this rhythm. And it's still not a P wave. You can try to make it one. It is not a P wave. It is this other type of wave that's going to happen to hit right before QRS complex. Sometimes it's going to make you think that. Do you see anywhere else? And the answer to that is no, right? So you can try to make it's the irregularity in this baseline here that's going to be causing them. There are no P waves. All right. The next one. Oh, this app. Okay.
So
Okay.
that last one, I'm calling that AFib.
Yeah, sorry, I didn't mean to move on. My finger is hitting the buttons instead of my pen on the iPad
I'm
here.
calling it as AFib.
Yeah, you're right. Okay. So we have an irregular rhythm coming from above the ventricles. There are no P waves here, so it's not sinus. Junctional, I guess, would be a possibility, but it's not typically irregular, so we rule that one out, right? So, and we have this irregular rhythm with a baseline that has some quivering in it. Now, it is fairly quiet because, the longer standing the atrial fibrillation has been around, tends to be that baseline tends to have a little less movement in it. But this is AFib all day long because of the irregularity and the lack of P waves. Okay. So atrial fibrillation is the correct answer. Anybody having problems with that?
So you ruled out the junctional escape because it's irregular rhythm, right?
That's correct.
Okay.
And the baseline's got, it isn't perfect straight. Now, sometimes when we get into artifact, that can confuse it, but this is, it's got this non-isoelectric baseline. There is movement there. It's not that perfectly straight, crisp, line.
Okay.
That helps us a little bit too, although it is a tough one. Okay. So the irregularity and the lack of P waves. All right. Next. Where'd that go?
What are you calling it, Katie? What are you calling it?
Jeez,
Straight out of the
Matt.
gate here. Okay.
Man, dude.
So we got to start. Let's go in order here, boys and girls. So let's go with the rate. Okay. Just looking at it, tell me, I don't want you to count out the rate. Is it fast or slow looking?
Fast.
Yeah, good. So we know it's going to be pretty quick. So what we can try to find the QRS complex. This looks fairly regular. There's a little bit of irregularity here for whatever reason, but most of it looks pretty regular. And so maybe we can try to find some land on a dark line here. This one looks like it's pretty close. So this would be 300 and this would be 150. So it's near 150. Okay. Do I care if it's 160 or 140? I don't. I'm not too worried about it. Let's just say it's 150. Okay. Everybody see that?
Yes.
Fast rate around 150. And we're calling this a regular rhythm. And what about, so the next
Wait, why
step
is it
here.
regular?
Why is it regular? So there is a slight irregularity here, but if you were to march out these QRS complexes, and they're a bit hard to see here, and you were to march these all out, you'd see that they're regular, okay? Slight irregularity up here, but for the most part, this is a regular rhythm. Is that, you see?
Yeah, so if it were consistently regular throughout the other leads, then you just call it regular. But one irregularity, you can't count it as that?
Well, you can, and it's, even with this rhythm, it would be okay to say it's got some irregularity to it, because this rhythm can fall into both categories. Okay, so there's a little irregularity there, maybe just because of a slight fluctuation in the ventricular rate, but for the most part, this is a pretty regular rhythm.
So,
okay?
Mr. Roberts, can I pause you right there?
Sure.
Your textbook says it's regular, irregular. You're saying it can go regular or irregular, but tomorrow is going to be multiple choice, A or B, regular, irregular. Which one are we going with for a flutter?
I wouldn't ask you a question like that. Oh, I wouldn't mean to ask you a question like that. How about that?
Okay.
If I ask you a question that says regular or irregular, then I screwed up and put choices on there that don't make sense. Okay. So yeah, a flutter, which is what this is, can have a regular ratio. Sometimes that the ventricular ratio will be off. It can go back and forth. It can absolutely do that. So the QRS here is narrow. We have, can you find P waves? For those of you who maybe had a hard time spotting this is atrial flutter, if you're looking 2 and 1, you might think those are P waves, but they're upright looking, aren't they? The 2 to 1 atrial flutter, which is what this is, meaning there's 2 flutter waves per QRS complex, can sometimes be hard to distinguish those flutter waves. But the good news here is that these QRS complexes are so daggum small that you can almost just see the flutter waves pretty easily, like that. You see?
Where do you
So
see the 2 to 1?
Sir, ma'am?
Where do you see the 2 to 1?
Okay, that's a good question. Let me see which lead would be the easiest to show you that. Okay, so here's a flutter wave, and there's a flutter wave, okay? And here is your QRS complex. So, and then here's another QRS complex there with another P wave, another P wave. So for every, so like this, okay? There are 2 flutter waves for every QRS complex. Sometimes those flutter waves will be, they're falling right on top and inside the QRS complex there, but there's 2 of these for every one of those.
So why would you have picked that over the AV nodal reentry, which has the same like rate? It's regular, the P waves aren't very clear.
Right. Well, because of the P wave morphology. So AVRT or AVNRT, which we'll have an example of in a minute, is usually going to be, oh boy. Okay, it's usually going to be a T wave QRS complex, T wave QRS complex. And you're right, it is tough, but it's the morphology. Instead of those pretty round waves, we have something that looks more like sawtooth. And so that's how you kind of just differentiate the 2. If you remember, the flutter waves are best seen here in your inferior leads, and in V1, they'll mimic P waves, okay? So it's really just the morphology. Yes, SVT, AV, NRT, those things will fall on the same rate, but it's the P wave morphology. Does that make sense?
Yeah.
Yes.
Sometimes in these faster rates, when it's 2 to 1, which unfortunately is the most common ratio for atrial flutter, those flutter waves are a bit harder to see, but they're there. And if sometimes you can cover up those QRS complexes with a piece of paper or something, you may be able to identify them a little bit easier. All right, so P waves, we have flutter waves, and that helps us give us an answer right there. PR interval pretty much doesn't matter. Okay, so that's a flutter. All right. Moving on. What do we got here? you were just to look at it, does it look slow, normal, or fast? Have you looked at enough where you can kind of judge it yet? If not, you can count it out. So here's one on the line right here. So 300, 150, 100, 75. So we have a rate near 75. And for our purposes, that's going to be fine. Okay. So we have a pretty normal rate. Is the rhythm regular or irregular? Regular. Okay. 3. Then we're looking for QRS, which so far everything's narrow. I'll just give you that. Next thing we look for are the P waves, right?
Yes.
So P waves and 2, 1, and AVR.
Mr. Roberts,
Yes.
where you counted off down there at the bottom and got 75? What if you were to do it up at the top? Because then if you would have done it like towards the top of the 2 lead, you would have got a little bit off of 100, maybe like 90 or something. You see what I'm talking about?
I don't. Which lead are you talking about?
Okay, lead 2, the very
Okay,
bottom.
lead 2.
Not
Oh,
the
at the
first
bottom?
QRS. Yeah, at the bottom. Not the first QRS, but the second one. If you were to do 300, 150, 100, wouldn't the rate be like 95 or so?
Yeah, okay, so you got 15. Anybody's got a calculator, I don't. So 16, 17. So instead of 20 blocks, you're closer to 17. This is probably a little faster than 75 because it's 1 block short there. So we have what did I say? 6, 15. Good grief. 19 blocks here versus 17 here. So it is a little bit different there. So some slight irregularity. But overall, it's a regular rhythm. Remember, it's got to be more than, is it 0.16 to make it irregular? Variation. All right. So again, clinically speaking, okay, it doesn't matter if we're going to get 80 or we get 70 or whatever. Okay. Is that okay?
Yes.
Can we be okay with that? Okay. Don't worry too much about it. I'll try not to throw too many at you on exam to mess you up. Okay. So we got a fairly normal rate. We got a regular rhythm. We got a narrow QRS complex. And what about our P waves?
It is upright in 1 and 2 and inverted in AVR.
Good. And that fits a sinus rhythm, right?
Yes.
That makes it easy. So we know we have a sinus rhythm here already. PR intervals are important for when we get to AV heart blocks. So even though we know what rhythm it is, we'll still want to eventually make sure we're looking at that. But for our purposes, we know we have a sinus rhythm, right? So we have sinus something. The reason we know we have sinus something is because the P waves fit the criteria, okay? So with a rate of 75, what type of sinus rhythm do we have? How about a normal sinus
rhythm.
Okay. Does that make sense?
Yes.
Okay, good. Okay, that will not let me zoom in, does it? All right, so we got another one here. I think we got 4 or 5 more, depending on how many more you want to do, okay? So number 1, we got rate, rhythm. We're going to be looking for QRS complex, P waves, and PR. Okay. So the rate, if you just looked at it, looked normal, fast, slow. Looks kind of slow to me. So
Slow.
300, 150, 175, 60, 50, way down there, okay? Somebody's got a calculator. 1, 2, 3, 4, 5, 6, 7, 8. About 8 full blocks. So 300 divided by 8. Somebody, I don't know. Anyway, we got a slow rate, okay? 42 maybe.
Sir,
So
for testing purposes, are you going to be putting rhythm strips in all these 12 leads, or are we going to have to do it off the count the blocks like you just did?
I'm not sure what you mean.
like a lead 2 strip at the bottom just to see the overall rhythm on a 12 lead instead of just having your separate leads, your 1, 2, AVR, AVL.
Yeah, some EKGs don't have a rhythm strip at the bottom. So if I'm being honest, sometimes they may, sometimes they may not. Shouldn't, it shouldn't mess you up. Even though the lead changes here, the rate would remain the same if you counted 30 blocks over, okay? Even though the lead changes, it shouldn't affect that if you're having to count out 30 blocks. That's what you mean.
Okay, thank you.
Yeah, it shouldn't affect that. So we got a slow rate. Is the rhythm regular or irregular?
It is regular.
Thank you, sir. We have a regular rhythm that's slow. Okay. What about our QRS complex? We know that's narrow. What about our P waves? Does it fit our criteria for a sinus rhythm?
Yes.
Good. So we have something that's from the SA node. So it's a sinus rhythm with a rate of 42. What is that called?
Sinus bradycardia.
Thank you. All right. Everybody getting that? Easy as pie, right?
Yes.
Okay. Here we got a rate, regularity, UA, so QRS complex really. Fast or slow, right? Looks like it's moving all along pretty quickly here. And it looks like most of these land on the line there. So we got a rate near 150, right? 300, 150. So moving pretty quick, kind of like our atrial flutter earlier, right? Is it regular or irregular?
Regular.
Good. The QRS complex is going to be narrow. What about our P waves?
There's no P waves.
They are gone. That's right. Okay. So they're none. So we don't have a P wave. We don't have a PR interval. All right. So we got a fast rate that's regular above the ventricles with no P waves. Let's think of what?
SVT?
Good. SVT. So atrial fibrillation, I think I might have heard somebody say that it kind of cut out, would be an irregular rhythm. The fact that this rhythm is regular rules out AFib, okay? So, and again, the reason this is not atrial flutter is instead of those pretty sawtooth waves that would be hiding up in there, we really don't have any P waves at all. Now, if you were to look really, really closely, sometimes you'll get these pseudo P waves, and you could probably try to make that be where those pseudo P waves are. Remember, you have, I'm sorry, pseudo R. So you might have a pseudo R there, which is actually a P wave. But those are hard to spot. And really, the main thing is that you see a T wave, QRS complex, T wave, QRS complex. Okay, that's a pretty classic SBT. Questions about SBT? So what would be the treatment options for this?
Sir, I got a quick question. Is there a general ballpark rate we can look at? And all right, so we're over this, we're in this area, we can assume or begin to look towards SVT over just sinus tach?
Not necessarily now. So if you think back to the video that we watched, basically I think he said there were 3 differentials for a regular tachycardia. You had sinus tachycardia, SVT, and atrial flutter, okay? So it's going to be one of these 3 things. And the reason that it's not atrial flutter, we don't have sawtooth waves. The reason not sinus tachycardia is we don't have P waves. So we're left with SVT. Okay. So the rate, unfortunately, is probably not always super helpful. Now, atrial SVT tends to be a lot faster than sinus tachycardia most of the time will be. So if you had a rate in the 180s, I'd probably be leaning towards SVT over a sinus tachycardia. But I mean,
Mr. Roberts?
Yeah.
How do you differentiate between like a PAC, like where the P wave is hidden within the T wave? Because that's what I thought this was.
Okay. Well, it would be constant PACs, right? If the PACs are hidden within the T wave, and basically that is SVT. You have all these. It's because it's coming from an ectopic atrial pacer. Okay. And so that is kind of what is happening here. Those P waves are hidden. Now, I think we've got it on the next slide. Okay. So these are PA. You have essentially a regular rhythm followed by this beat that comes earlier than it should. So something weird's going on here. Those are kind of paced out, and you've got this one here, these outliers here. Okay. So trying to figure out what those are. And you can see that the T waves of these look different than that. And that's because those P waves are hiding inside of here. Okay. So these are your PACs here. So PACs are usually an occasional occurrence like this. Now, sometimes you may get a few in a row, but when you get, if it's constant like this, then basically you've got SVT. Okay. So the full interpretation of this would be a sinus rhythm with PACs. Okay. And so these are your PACs right here.
Mr. Roberts, do you want us to be able to like you need to like say non-blocked or aberrant? Do we need to be able to differentiate all 4 types of PACs?
No, I probably should make this more clear. The only reason that I describe it that way or put it in the book that way is just to help you to identify them, because all PACs don't look alike. It doesn't really, as far as clinical practice or as far as I'm concerned, you don't have to tell me what it is. But I just want you to know that they can look different in different circumstances, so you can identify them. So it's more for your benefit than it is anything you have to describe to anybody, if that makes sense. Yeah. All right, a couple more here, I think. Okay. So let's do this one from the top. We have a rate. Somebody go ahead and just shout it out when you got it. Are you all going to make me do it? Just like my children. All right, 1, 2, 3, 4, 5. We have 5 big blocks, which would be 25 plus 1, 2, 27, plus maybe 1, 2, so 20, 29. So 300 divided by almost 30 is 100, right? So we're in the neighborhood of 100. Does that make sense? Okay. So the rate is around 100.
Where we were counting like 55, 60.
I probably did it wrong in my head. Okay, yeah, because it looks slower than that, doesn't it? 300, 150, 100, 75, 60, 50. Okay, daggum. How about 55? Is that what you said? Somewhere near 60?
Yeah.
Yes, sir.
Okay, my bad. Okay, so somewhere in that neighborhood, it is on the slower side. Regularity, does it look regular or irregular?
Regular.
Irregular.
Looks irregular.
Looks regular.
Yeah, there's some, I mean, I can see where you're coming up with the irregularity. It looks a little wider here. I think it's a change in the rate. And that's why sometimes you'll get these variations, just simply because the rate's speeding up or slowing down. Obviously, it's not going to be perfectly static at all times. For the most part, it looks like a fairly regular rhythm. Does the QRS look narrow or wide?
I think it's delta wave.
Ah, okay. So with the QRS complex, looks a little wider than normal, right?
Yes.
So if you look at this one, it starts here in V2, starts right almost on that dark line, and it finishes with only one block left in that big block. So it tells me it's got 4 big blocks. It's about 0.16. I mean, it's 4 small blocks. Does that make sense? So if that QRS complex starts right there on that line and ends with 1 block left, then we know it's got 4 small blocks. 4 times 0.4 is 0.16, okay? And that's wide. So we have a wide QRS. What about the P waves? So we see those right here. Does that fit our definition for sinus?
Yes.
Did everybody
Yes.
with me? Okay, sinus
Yes.
rhythm. So we have a sinus rhythm of some sort with a rate that's kind of slow. What about our PR interval? Look right here.
It's short or non-existent.
Yeah, so very short. And somebody mentioned it already. There's already what looks like kind of a slur going into that QRS complex here and here. And that is, this one's a really good example right here, right? And that's a delta wave. So, and you can see that it fits the definition for Wolff-Parkinson-White because it's got the wide QRS, it's got the short PR intervals, and you have the delta wave. And that's that triad that we talk about for WPW. So WPW is a condition the patient has. Now the rhythm is still either, depending on what we calculate the rate to be, a sinus bradycardia, and this patient has WPW. So your full interpretation is not WPW. It's the patient has sinus bradycardia, name the rate, and the patient has Wolff-Parkinson-White. Does that make sense? The rhythm is not Wolff-Parkinson-White. The patient happens to have findings also consistent with that.
Mr. Roberts.
Yes.
So does the WPW should be, it has to be regular or irregular? Or it don't matter?
It doesn't matter.
Okay.
Yeah, it's these 3 things here, the wide QRS, the short PR, and the delta wave.
Okay.
Do we need to know the different types of SVTs or just SVT in general?
Yeah, now, so if you're talking about with Wolff-Parkinson-White, you do, I want you to know the instances in which you see them. So with let me get a different color here.
No, not with WPW. I'm saying with like SVTs where you can have your PAT, your MAT, your WAP. Do you want us to know each of those individually or know that those collectively all make up SVT?
Yeah, just know that they make up SVT. So because AV, RT, and AV and RT are going to be indistinguishable on the EKG. The only way you can kind of hypothesize is this one, AV-RT, is that you know that the patient has Wolff-Parkinson-White. Okay, these are connected, a bit, and so that's why they get that rhythm. But looking at it on 12 lead, they're going to look exactly the same.
Okay.
I'm not going to ask you to identify that, right?
Would you be
Okay.
willing to send us this PowerPoint in an email?
Yeah, I think I have. Yes, I can do that. I think this is also being recorded. Not that you want to go back and watch all this, but I think I can try to send that as well.
Thank you.
Yes. Here we go. I think this is the last one. Okay. So we'll do this one real quick, and then you guys can ask questions or whatever you need to. So we're looking at a rate. We're looking at for the regularity. We're looking at the QRS complex. We're looking at the P waves, and we're looking at the PR interval. Okay, these are our steps. All right, so the rate. Here's one that ends on the line. So 300, 150, 100, 75, 60. So somewhere in the middle of that, let's just say 67. Split the difference, okay? Look regular or irregular?
Regular.
Good. What about the QRS complex? Narrow or wide? Almost looks like it kind of is a little wide, doesn't it? 1, 2, 3. It's right at that, right at the cutoff there. So, anyway. not greater than, but it's right there at it. Okay. Narrow QRS. What about the P waves? We're looking in lead 2, 1, AVR. What do you think about those?
Are those flutter waves or they look like?
Yes, sir. Yep, you got it. They're not normal. It's not a normal P wave morphology. So even though the complexes here are upright, and 2, you got an upright in AVR, which tells you something's weird. And you look at these classic sawtooth wave here, right? So, yep, atrial flutter. And it helps when the rate's not so stinking fast. You know, these are real pretty, easy to pick that out. And remember, in V1, those flutter waves will look like P waves here on these right-sided chest leads. Inferior leads tend to be the best ones for picking up those flutter waves. You can see they're nice and crisp over here, a little less so in these other leads. So the inferior leads are going to be your most helpful for finding those flutter waves. And the right here, and your P waves looking up here. Okay, good job. That's all the ones I had to go through. Questions about of this stuff we haven't covered?
I have a quick question.
Okay.
So you listed one of the conditions or the characteristics of the AFib rhythm, that it has to be tachycardia. And in the homework, there's some AFib and they are bradycardia, like 45 or 55.
Yeah, it shouldn't. No, it does not have to be tachycardic. So let me see if I can pull the slide up here. Was that something you thought you read in the book or something that was in the
I'm not sure. Let me look at it.
Okay. So commonly, I think maybe what you're remembering is that commonly, yes, the rate's going to be fast. I think usually without medications or something like that, the rate can oftentimes be 110 to plus. But atrial fibrillation, especially for patients on treated for it, beta blockers, calcium channel blockers, then the rate can be slower.
Is there any difference between the regular rate and the ventricular rate? Because you listed in the characteristics, the ventricular rate is variable, 90 to 170 beats per minute.
That's right. So yeah, I mean, so you're talking about, is the atrial rate and the ventricular rate different in fibrillation? Yeah. So the atria are these, is it gonna let me draw? Yeah. So the atria are these quivering lines right here, and they're moving super, super fast. So fast, in fact, that I can't count them. But so we know, and then the ventricular rates are obviously your QRS complexes here. So yeah, your atrial rate and your ventricular rate in atrial fibrillation are different.
Okay.
And same thing with atrial flutter. I mean, every time you have one of these flutter waves, that's the atrial rate, right? And this is your ventricular rate. So your ventricular rate's slower than your atrial rate.
Okay.
All right. So yeah, unlike a sinus rhythm where every P wave's got a QRS complex and every QRS complex has got a P wave, we've got the atria overfiring, overdoing its thing. And fortunately, the AV node with its decremental conduction is slowing stuff down. So we don't have an atrial flutter rate of 300 or whatever, you know? So yeah, they'll be different.
Okay.
All right. Anything else? Got real quiet.
I have one more question before we leave.
Okay.
So
okay.
I'm just literally confused about the Ashman's phenomena. I don't know how to identify that phenomena, or Ashman, whatever.
Yeah, it's not something that I'm typically too worried about you being able to identify. Just that you know it's there. I'm having some trouble with my screen. There we go. Where is that at? I had a slide on it, right? Or no?
Yes, we had a slide for it.
Oh, here it is. Here it is. Okay, here it is. So Ashman's phenomenon is just anytime you've got these atrial fibrillation, okay, so we can see that this is an irregular rhythm. Our R to R intervals are irregular. There's no clearly identifiable P waves, and the baseline is not isoelectric. So that fits our criteria for AFib. Now, in atrial fibrillation, sometimes you're going to get these aberrant looking beats like this, and that's from something called Ashman's phenomenon. And so if you remember, the right bundle branch remains refractory longer than the left bundle branch. So as the impulse is coming from the atria, if it hits the AV node and travels down before the right bundle is ready, then you get kind of an aberrant complex. And that's what's happening here. You end up getting this long cycle followed by a real short cycle where there was a long duration before the atrial impulse reached the AV node, and then a real short, quick turnaround. And that meant that at this point, man, I'm getting really covered up here. This is where the right bundle remained refractory. And so you get just this abnormal looking beat. That's the only thing you need to know about it. It's an abnormal beat that happens in atrial fibrillation because the right bundle was not ready to deploy.
Refractory, yes, got it.
Okay, sorry, that was a real long explanation for something that was probably not that important.
Okay.
Don't worry about it too much.
Okay.
Anything else? All right, guys, I will see you bright and early in the morning. If you need something before then, shoot me an email, give me a call, okay?
Thanks, Mr. Robert.
You're welcome. Well, have a good night.
Thank you.
You too.